Hello, everyone. My name is Charlotte Stubbe, and this is my PowerPoint presentation on preventing venous thromboembolism, or VTE, in hospitalized patients, a synthesis of recent quantitative evidence for my evidence-based nursing class for the bachelor's program at St. Petersburg College 2025. Today, I'll be presenting a synthesis of recent research on preventing venous thromboembolism, or VTE, in hospitalized patients. The purpose of this presentation is to critically review 3 recent quantitative research studies and highlight what works, where gaps exist, and what the implications are for nursing practice. My guiding questions are: which interventions improve appropriate VTE prophylaxis and patient outcomes, and what areas remain underexplored? Along the way, I'll also connect this evidence to guidelines and supporting literature. VTE, which includes deep vein thrombosis and pulmonary embolism, remains one of the leading causes of preventable hospital deaths worldwide. Despite strong evidence and established guidelines, prophylaxis is often underused or inconsistently applied. Missed risk assessments, workflow barriers, and patient discharge gaps all contribute to the problem. Nurses are at the forefront of VTE prevention by conducting risk assessments, ensuring timely administration of prophylaxis, and educating patients. For this reason, nursing practice is central to reducing preventable harm from VTE. To select evidence, I searched databases such as PubMed, CINAHL, and Cochrane, limiting results to English language studies between 2019 and 2025. I focused on primary quantitative studies, including descriptive, quasi-experimental, and randomized designs that examined inpatient VTE prevention. 3 studies were selected: a quality improvement project in Dubai by Parmar and colleagues, a cluster randomized trial of a clinical decision support tool by Spyropoulos and colleagues, and a cross-sectional study of health professional knowledge and practice by Hussein. Together, these represent system-level, process-level, and human factor approaches for VTE prevention. The first study is a quality improvement project by Parmar and colleagues, published in BMC Health Services Research. This study reviewed records of over 700 adult inpatients in a private hospital in Dubai. Almost every patient was risk assessed within 24 hours, and about 40% were identified as high risk. However, fewer than 30% of those patients actually received pharmacologic prophylaxis. Importantly, no hospital-acquired VTE events occurred during the study period. But the gap between risk assessment and prophylaxis administration highlights a breakdown in translating assessment into action. For nurses, this underscores the importance of ensuring that risk assessments lead directly to timely interventions. The second study is a cluster randomized controlled trial conducted by Spyropoulos and colleagues in 4 academic hospitals. They tested a universal electronic clinical decision support tool linked to risk assessment models such as Improve-DD. The intervention significantly improved the rate of appropriate in-hospital prophylaxis and also increased the number of patients discharged on appropriate extended prophylaxis. There was also a signal toward fewer 30-day VTE events. This study shows that well-designed electronic tools can help close the gap between recognizing risk and actually prescribing and delivering prophylaxis. It highlights the power of system-level interventions. The third study, a cross-sectional doctoral dissertation by Hussein, examined knowledge and practical factors related to VTE prophylaxis among healthcare professionals. The finding revealed gaps in both knowledge and consistent practice. with differences observed across professional roles. The study points to the human factor side of prevention. Policies and tools can only be as effective as the staff who implement them. Ongoing education, training, and reinforcement are critical to ensure that all healthcare professionals apply prophylaxis appropriately. Taken together, these studies tell a consistent story. First, system and tools like electronic clinical decision support improve adherence to guidelines. Second, process reliability is still lacking. Assessment doesn't always lead to action. And third, human factors such as knowledge gaps and attitudes can limit effectiveness. These findings align with the 2021 American Society of Hematology guidelines, which stress risk stratified use of pharmacologic and mechanical prophylaxis. Effective VTE prevention requires integration of systems, processes, and people. Nurses, these findings translate into several practice implications. Nurses can lead or participate in protocols that directly connect risk assessments with default prophylaxis orders, while also monitoring for bleeding risks. Nursing staff play a key role in ensuring timely administration, which is critical for effectiveness. Patient education is also essential. Using teach-back methods can help reduce refusal or confusion about anticoagulant medications. Finally, nurses are often the ones coordinating discharge planning, making it important to identify high-risk patients who may benefit from extended prophylaxis after hospitalization. There are some limitations across these studies. Quality improvement in observational designs, such as the Palmer study, cannot establish causality. Single-centered settings limit generalizability, and even in randomized studies, adoption of clinical decision support varies due to alert fatigue. The cross-sectional study by Hussein points to knowledge gaps, but cannot explain why they persist or how best to fix them. Overall, we need more data linking interventions not only to adherence, but also to patient improvement outcomes like reduced hospital-acquired VTE, fewer bleeding events, and lower mortality. Evidence from these studies supports several recommendations. Hospitals should adopt mandatory clinical decision support systems that connect risk assessment with default orders while building in safeguards for bleeding risk. Nurse-led education programs and audit feedback cycles can help address persistent knowledge and practice gaps. At the same time, outcome tracking should go beyond process metrics to include actual VTE and bleeding rates. Aligning these practices with the ASH 2021 guidelines ensures consistency with evidence-based standards. To make change measurable, SMART goals are helpful. For example, within 6 months, increase the rate of appropriate in-hospital prophylaxis on medical units by at least 10 percentage points, verified through chart audits. Another goal could be reducing missed or late doses by 30% within 6 months by implementing nursing administration bundles. Longer term, within 12 months, increase the proportion of high-risk patients discharged on appropriate extended prophylaxis by at least 8 percentage points. These types of measurable goals allow progress to be tracked and sustained. In conclusion, the evidence shows that preventing VTE in hospitalized patients requires a coordinated approach that brings together system-level tools, reliable processes, and well-prepared healthcare providers. Nurses are critical to this work. They operationalize risk assessments, ensure prophylaxis is given on time, educate patients, and coordinate safe discharge. Next steps include scaling up CDS-enabled pathways, investing in ongoing staff education, and continuously measuring outcomes. By doing so, we can make real progress in reducing preventable VTE and improving patient safety.